Hello, I'm Dr. Douglas Weston. I'm Assistant Professor of Osteopathic Principles and Practice at Pacific Northwest University College of Osteopathic Medicine. The topic for today is pulmonary asthma. However, you will see that I will be talking about some other lung diseases so you can compare how asthma and these other ones share some features and have some distinctive features. You'll notice that I spend a fair amount of time on pathology, and it is my belief that the understanding of why you do certain techniques and why you do certain approaches is predicated on a good knowledge of the specifics of the underlying pathology. And so we will spend a fair amount of time dealing with those issues. Okay. So goals and objectives. Everywhere you study osteopathic manipulation and you're working with pulmonary, you talk about sympathetics and parasympathetics. I'd like to speak to why those things, certain physiology of the autonomics pertain more towards some lung diseases than others. You can see that bacterial pneumonia, interstitial pneumonia, and asthma are going to be covered. I'm also going to talk a little bit about COPD. All right. Let's see where we are. Okay. So we need to go over, in a little more detail, the autonomic effects on the lungs. So parasympathetic effects on the lungs. We all know it induces a proliferation of the ciliated cells that produce a thin mucus, which helps clear mucus out of the bronchial tree. Parasympathetics also promote bronchoconstriction. So the pros and cons of this, certainly when we are relaxed and the parasympathetics are dominant, we want to clear mucus away from the bronchial tree. Bronchoconstriction allows the lungs to be more or less protected, and the ciliary clearance is augmented. The pros, so it vacuum cleans the lungs. The cons is prolonged bronchoconstriction can cause bronchial smooth muscle to grow larger and to get overly bronchoconstricted. Similarly, the parasympathetic stimulation of the lung induces the proliferation of goblet cells that produce a thick, sticky mucus. And it promotes bronchodilation. This is very useful in times of stress where you need to move a lot of air. The thick mucus gives some piece of protection when we're bronchodilated. And there is some vasoconstriction of the bronchial vasculature. The pros is bronchodilation helps coughing up of large pieces of mucus. So if you have mucus production that's augmented, a little bit of sympathetic stimulation is needed. The cons, of course, is that you produce a thick mucus that's very tenacious, very difficult to expectorate, and it's a perfect growth medium for bacteria that happen to be there. So let's take a look at bacterial pneumonia. The host organism response is very specific depending on which microorganism is invading, but there's some general pieces that are the same. First of all, it gains access to the alveolus. That's how it gets down there. The host response is red blood cells and neutrophils migrate into the alveolus, and then the neutrophils destroy the bacteria, the macrophages ingest the fragments, and all this resultant is carried up through the mucociliary elevator. Okay. So what happens is, yes, when there's a bacterial pneumonia, we want to preserve lymphatic drainage. As you can see in this left diagram, a macrophage is going into the lymphatic system, presenting its antigen to the lymph node. So that's a useful thing to happen. And yes, we don't want too much bronchoconstriction because of the problem of coughing up of mucus. So we want to prevent excess parasympathetic stimulation. But the primary thing that we're looking at is exaggerated sympathetic stimulation of the lungs, because this produces a very thick, tenacious mucus, and clearing up of bacterial pneumonia it's crucial that you have good clearage of the debris that's in the bronchial tree. So we're very concerned about hypersympathetic stimulation when we have a bacterial pneumonia. So the causes of increased sympathetic outflow that you commonly find when you have a bacterial pneumonia are somatic dysfunction of T1 through 6 and associated ribs. Okay, we all know that. Also, the sympathetic system is stimulated by stress, and so when a patient has increased work of breathing, the sympathetic nervous system is stimulated because of the stress of that. Certainly when you have chest pain at the same time that you can't breathe, it also increases the sympathetic stimulation. So that when we are doing osteopathic manipulation for bacterial pneumonia, we want to make sure that we've taken care of somatic dysfunction at T1 through 6, we've decreased the work of breathing, and we've treated any chest pain that might be going on concomitantly. So this is what I have just explained. You have the slide here so you can see it at your leisure. So the office treatment of this. So I'm going to demonstrate what's often done in the office, and then I want to add one piece of it that I find that is sometimes not addressed adequately in my belief. Okay. Mr. Childers. Okay. Have the seat facing that way. Wait. Let's see. There we go. Okay. So the office treatment of somatic dysfunction for T1 through 6, certainly what I've seen is that, and do I need to rotate this to get a good side view? Are we okay? All right. What we often see is treatment involved where you find somatic dysfunction here, and you can put them into side bending and rotation and do muscle energy very easily. If somebody has a flex dysfunction, that is there's increased thoracic kyphosis, you can have them, while you're doing this, stick their chest out. So stick the chest out, you side bend them, you rotate, and you have them de-side bend away from the barrier. I see that done very well in the clinic and in the hospitals. However, in the upper thoracic spine, what I often see is, in order to get extension, is the head goes back. This is very difficult for a lot of patients who have OA problems and cervical spine problems. And so if you look at the diagram on the slide, this is how I suggest you do it. So you have the person tuck their chin in, and you have the back of your hand, the bottom of your hand, pushing forward. So now I have extension because his chin is pushing back. He's extending above the segment, and my hand here is extending below the segment. Now if you do this type of movement with his still pushing his chin back, I can feel a good extension component going against the barrier of increased thoracic kyphosis. So now he pushes up against my hand, and I'm treating now to increase extension. And then keep going, he tucks his chin in again till we get extension, etc. So the tucking in of the chin, the pushing the distal segments into extension, I think is a very good way to treat increased thoracic kyphosis when you have somebody who is hunched forward. Okay, thank you very much. So respiratory problems in hospitalized patients. Certainly you could do this, the technique I just showed you, with a hospitalized patient, and yet most of them are going to be supine on the bed, and they're in the hospital because they can't get up and do these kinds of maneuvers. So I'd like to show a subset of osteopathic manipulation that's geared towards your hospitalized patient. And in fact, I could use your services once again. Sorry about that. So as you can see in the diagram, I have my fingers over, go ahead and just lie down, face up head here. I have my fingers over the spinous processes, and the skeleton diagram and the patient diagram shows what that would look like in practice. Now, diagnosis, we're all used to having a patient prone or having them stand and get our segmental diagnosis. I'm not even concerned right now with side bending and rotation as much as I am what areas are restricted in his spine and rib cage. And the easiest way to start doing that is what I would call just springing the spine and seeing where it's restricted. So you start with the lumbar spine, and all I'm doing is springing on my way up. So lumbar spine is fine. Thoracolumbar junction is starting to have some issues. Now about T8 and 9, even more. So about T8 is the center of the restriction, and then it starts getting a little bit more mobile as you go up. So I would focus my spine treatment at T8. Now, again, we could use lots of different techniques, but I think the best way to begin with a hospitalized patient who might have many tubes and wires, and you're in an environment where you can't really position them the way you would for another technique, is simply spine raising. And you just put your fingers on the area that's restricted, and you raise it up until you get this sense of floating. That is, the spine now is being pulled equally in all directions, and you just hold it. It takes a little bit of patience to sit there doing this, but it's very effective. The next piece, are we looking at slides as well? Well, I'll try and have the slide parallel it in case that would be something useful. So spine raising is the treatment. Rib raising everybody knows about, and the diagnosis is the same principle. And frankly, I would do the spine and rib diagnosis first and the treatment afterwards, but just for exposition purposes, I'm separating them. So you would spring the ribs. You're just putting your fingers on the angle of the ribs and you're springing them upwards. And indeed, about T7, T8, he has some ribs where they don't spring, loss of compliance. And you can do rib raising there. Everyone knows rib raising, it's raising up and a little bit lateral to disengage the ribs from the spinal cord. Very effective in hospitalized patients, those two, spine and ribs, who have respiratory problems. And I'll go over the pathophysiology in a moment. Okay, thank you. In contrast, interstitial pneumonia doesn't behave the same way. The bugs that produce the bacterial pneumonia get into the alveolar spaces and adhere to the walls. The organisms that cause the interstitial type pneumonias do something else. They invade the type 1 pneumocytes and they cause edema in the actual walls of the bronchial tree. And so you can see in this diagram, the upper diagram shows the thin-walled bronchial tree of a normal person. In the lower diagram, you can see the edematous walls that are caused by interstitial pneumonia. So the implications are that because the edema is in the alveolar walls, that for interstitial pneumonia we are very much concerned with lymphatic drainage. So the question is, what things can we do to optimize lymphatic drainage from the lungs? First of all, the thoracic outlet, which is comprised of T1 and 2, the first rib and the clavicle, is a spot where the lymphatics flow into the venous system. It's a very crowded location and very easily compressed, and that would compress the end drainage of the lymphatics, and then anything prior to that would also start to back up. Similarly, the thin-walled lymphatics are also very easily compressed by malpositions of the rib cage. That is, increased thoracic kyphosis, lateral curves. Those types of things can block the lymphatics as they actually flow through the rib cage. And finally, we have to deal with how fluid goes from the interstitial space into the end lymphatic. It's been shown with micropipette studies that the hydrostatic pressure that coming out of the capillary is very quickly dissipated, and that there is no pressure gradient driving interstitial fluid into the end lymphatic. And in fact, what happens is that you need a fluctuating fluid flow to drive the interstitial fluid into the end lymphatic, and it stays there because of the one-way valves in there. This fluid fluctuation in the lungs is provided by the movements of the rib cage, so it's very important to get the rib cage open. This next slide, let's see. And so, we've talked about the point at the top. The next point that we want to talk about is that for all pneumonias, both bacterial and interstitial, are involved with an increase in fluid. Increase in fluid inside the alveolar space for the bacterial, inside the walls for the interstitial. Water has a very, very high surface tension, and so the increase in the fluid here creates a large amount of resistance to inhalation of the lungs. That means that we really are concerned with getting rid of the excess fluid, but we also want to decrease the work of breathing. It's another reason that we want to do something like this. So for balanced ligamentous tension of the thoracic outlet, Mr. Childers, if you're available, we'll demonstrate this. Face up, head here. So basically we have three axes here. We have a vertical axis. Rotation would be like a steering wheel. We have an AP axis. Rotation along that would be pushing one shoulder up or down. And we have a transverse axis. Rotation there would be a twisting like the wringing of a towel. So what we want to do is, if there is some restriction in motion or malposition of any of these aforementioned structures, we want to balance it and let the breathing just untwist the whole area. So you find where on a vertical axis it wants to go, and he wants to rotate this way, turning the steering wheel to the left. AP axis, his right shoulder wants to go down. Twisting axis, right shoulder wants to twist forward compared to the left. So you balance off these, stack them one by one, and then hold it and wait for it to release. You may have the same response I did to initially learning this, that this really can't be that effective. But I've seen rock-hard thoracic inlet structures release within 15 to 20 seconds using this. So this is a very effective technique. It's also a very effective technique with a supine hospital patient who really can't move around that much. Okay, thank you. So now we're going to talk a little bit about obstructive lung disease, COPD, bronchitis emphysema. So the immune system sends neutrophils in to kill the invading microbes. And the neutrophils act, at least one of the ways that they act is by releasing substances that kill the invading bacteria. And one of these substances is this protease called elastase. And so what we have the problem is, of course, the elastase destroys the protein in the invading bacteria, but it can also destroy the protein in the bronchial walls. And so the body secretes an enzyme called alpha-1 antitrypsin to protect from that. However, under certain circumstances, this doesn't work very well. And one of them is cigarette smoking. So it's an irritant, it causes inflammation in the alveolus, triggers the influx of neutrophils. Okay, this we know already. And the neutrophils release elastase. Now the problem is that the cigarette smoke also deactivates the alpha-1 antitrypsin. So then this elastase will actually destroy the walls of your own bronchial tree. So your immune system attacking yourself. So for emphysema, we want to drain off inflammatory mediators. We want to do that, and we want to do that very aggressively, or else you will get damage to the walls of the bronchial tree. Okay, now for asthma, we'll put all these things together. We will need to do all of them, and let's go over the slide. So under early phase, there's a release of leukotrienes, prostaglandins, causes bronchoconstriction, okay? And so this is where you have the parasympathetics are overdominant. The parasympathetic overdominance is very similar to what happens here. And so the danger is that with asthma, if the parasympathetics are hyperstimulating, you have both the bronchoconstriction from the leukotrienes and you have bronchoconstriction from parasympathetics, and this can be a big problem. These same leukotrienes also cause increased mucus production. So if you have this effect going on and you have excess sympathetic stimulation to the lung, now you get a large amount of mucus, and in fact the mucus plug is a very big problem in asthmatic patients. Also, there's inflammation of the wall of the bronchial tree and damage to the epithelium there. And there are a number of things that this damage causes. Basically, the damage to the wall is very problematic, and this is why that you really need to get good lymphatic drainage out of an asthmatic patient. I would say that that would be almost a crucial element to prevent long-term damage from an asthmatic attack. So on the bottom, 1, 2, 3 are all talking about the 1, 2, 3 things in the early phase, why we need to have all 3 of them. I put a late phase diagram here to show that in fact asthma just keeps going and going, and the interventions that we have for the early phase are also relevant for the late phase. And if you don't catch it early, if you catch it late, you can still do a lot to stop the progression of long-term asthma. Okay, Mr. Childers. I think we have one more here. So the only part of this that we haven't talked about, okay, we've talked about the lymphatic drainage, same position. We've talked about treating sympathetics from T1 through 6, is talking about parasympathetics. And the one technique that's particular to the parasympathetic part of this is the OA. The vagus is coming out of jugular foramen. It also is very close to the surface and very close to a number of muscles in the upper cervical spine. So you need some way to work this area to prevent hyperparasympathetic stimulation. A very, very easy way to do this is to put your fingers in the occipital sulcus and you just pull your fingers upward. Okay? Your fingers are there, they pull it upward, and you let the weight of the head rest on your fingers, and it just releases the tissue in this area. Now, the really nice part about this, for people who've done this type of treatment and are very comfortable with it, you can add one more thing. I would say that those of you who haven't done this and you're just beginning, just by putting your fingers in here and letting the head rest on your fingers, you can get a lot of leverage. For those of you who want to take it a little further, what you can do is you can fine-tune it. Where exactly is the restriction? And you can pull your fingers upward. You can traction cephalad, or you can separate your fingers. And this will help treat condylar compression for those of you who have studied some cranial and know what that is. So this technique is good for beginners, and it's good for those people that have had a lot more experience. It's very powerful. The nice part for beginners is as you do the part that you can do, then you can the technique will allow you to gradually grow into more advanced techniques in the area. Okay, thank you. Okay, so now we're getting into some of the review and drilling pieces of this. So asthma is characterized by mucus plugs in the respiratory passages. This means that you have a lot of mucus in the lower respiratory tract, and this is the perfect growth medium for bacteria. And so what happens is that if you don't treat asthma well, you are predisposing this person to developing pneumonia. And so now the question comes, if you have an asthmatic with superimposed pneumonia, which kind of restriction do you like to see? An inspiratory restriction or an expiratory restriction? And really you need to ask yourself the question, for an asthmatic who's recovered from a pneumonia, which muscles will be hypertonic? That's what we're looking at, muscles of inhalation or of exhalation. And we'll answer that question in a bit. So, summary here. For bacterial pneumonia, we're concerned with mucociliary clearance, so we want to prevent excessive sympathetic stimulation. For interstitial pneumonia, we're concerned primarily with lymphatic drainage. and we need to maintain the amplitude of respiratory movement to drive that interstitial fluid into the lymphatic, end lymphatic, and the patency of the thoracic outlet to not block the lymphatic flow at the very last spot. For asthma, we're concerned of all of it. We want to prevent excessive sympathetic stimulation so that the mucus plugs don't become a huge problem. We want to maintain lymphatic drainage so that the inflammatory component is not, does not create long-term problems. And we make sure that you don't have bronchoconstriction from excessive parasympathetic stimulation to the lungs. So now, pneumonia versus asthma. So pneumonia, we've seen that because there is increase in fluid with its high surface tension, that there's an inhalation restriction. That is, there's a problem with inhalation. Inhalation will be very labored. Asthma alone will tend to show an exhalation restriction because of the predominance of bronchoconstriction, and when the lungs start to contract, those very thin lumens from the bronchoconstriction now close off very easily. Here are the sources that I got a lot of this information from. You can check it to get a better explanation of things that might not have been clear enough. Okay, so that concludes the pre-recorded section of this presentation, and now we'll take questions. We also have a post-test for you to take, and thank you for your attention.